We'll move on to the next guest lecture. So the next guest lecture will be chaired by Dr. Pichmani sir, organizing chairman. And we have our next speaker, Dr. S.N. Narasingan sir, MD, FRCP, FACP, FICP, FCCP, USA, Vice Chairman, Lipid Association of India, Board Member, World Hypertension League, Immediate Past President, Indian Society of Hypertension, Elected Fellow of International Society of Hypertension. He'll be talking on the topic, Management of Diabetic Dyslipidemia. Should we focus on lipid levels or decide as per risk categories? Thank you. Over to you.
Welcome, sir, and President Narasingan sir doesn't need any introduction to this audience. He's a number one lipidologist in India, I would say, and he's been practicing lipidology for quite some time, and I'll go to Narasingan sir.
Thank you very much, Chairperson, for the nice words. Morning to everyone. At the outset, I would like to thank Dr. Arulraj and his team for giving me this excellent opportunity to be with you this morning to talk on diabetic dyslipidemia. I am raising two important questions. Managing diabetic dyslipidemia. Should we focus on lipid levels or decide as per categories? Way back 1933, there was a mention about atherosclerosis in the journal on arteriosclerosis. In the absence of hypercholesterolemia, particularly the raised to LDL cholesterol or the remnant particles, it is virtually impossible to cause atherosclerosis in an experimental animal. The role played by LDL cholesterol is very, very important, not only in the initiation of atherosclerosis, but also in the progression of atherosclerosis. There are good number of evidences. The best evidence is from familial hypercholesterolemia, where the LDL levels are abnormally high, push patients for an early premature coronary artery disease and death. There are a number of studies like molecular studies, biological data, and the epidemiological studies, observational studies. But out of all these evidences, I would rather pick up the randomized control trials, which had used the HMG coenzyme A reductase inhibitor, statins. The more the number of reduction of LDL cholesterol witnessed in primary prevention trials and secondary prevention trials had gone to prove that there is a reduction in cardiovascular morbidity as well as mortality. That's the best evidence. So our prime focus of prevention of atherosclerotic cardiovascular disease must be lowering LDL cholesterol and keeping it low throughout life. Let me try to dwell on the diabetic dyslipidemia. What are the lipid abnormalities seen in people with diabetes? In type 1, the lipid abnormalities are almost similar into controls as far as the glycemic control is good. When you talk about the type 2 diabetes with the dyslipidemia, it is a characteristic dyslipidemia which we call as atherogenic dyslipidemia, where the triglycerides are going up, the HDL cholesterol are coming down, the increase in the LDL particles, increase in LDL cholesterol, and increase in VLDL cholesterol, increase in non-HDL cholesterol. But the LDL cholesterol sometimes, mostly it is normal or even below normal. When there is a poor glycemic control, even in type 2 diabetes, the abnormalities remain, except that there is an increase in the LDL cholesterol also. Having seen this, I need to tell you that the triglyceride component of the lipid abnormality which are encountered in people with diabetes are always associated with increased coagulability, plasminogen activator inhibitor levels go up, factor 7 levels go up, the activation of prothrombin to thrombin also occurs in those people with hypertriglyceridemia complicating diabetes. The terminologies that are used in lipid and lipoproteins is the non-HDL cholesterol. The total cholesterol, you remove the HDL cholesterol, which we consider as an anti-atherogenic. The rest of the things are all atherogenic particles. It includes the LDL cholesterol, IDL, VLDL, VLDL remnants, chylomicron remnants, and lipoprotein little a. So simply you have to subtract the HDL cholesterol from the total cholesterol. Whatever the value that you get, that is non-HDL cholesterol. We measure triglyceride, we measure HDL, we measure directly the LDL cholesterol, sometimes Friedwald formula used, mainly for epidemiological studies. The remnant cholesterol, which attracts our attention now, It has been proved now beyond doubt. They play an important role over and above the LDL cholesterol for increasing atherogenesis. How to calculate the remnant cholesterol for clinicians? Total cholesterol minus HDL, you have non-HDL. Remove the LDL also, whatever is remaining, that is actually the remnant cholesterol, which again is very important for atherogenesis. Of course, we also measure lipoprotein little in almost all our patients, either for the first time or subsequent visits also. If you look at these three plasma, which are seen on the left side, you can just see the LDL cholesterol is high, lipoprotein little high, push patients for an early coronary artery disease. The middle one is a turbid plasma, where you have an increased remnant particles, increased triglycerides, which pave the way for these individuals to get into cardiovascular diseases quickly. The last one, it is actually the milky white serum, which contains excess chylomicrons, excess triglyceride, which push patients for pancreatitis. Of course, cardiovascular disease is less common. So let me now again go back to the title what I have already given you. Should we focus on lipid levels? That is the first one that I thought I should discuss. Go back to the good data that we had obtained from CARD study. CARD study is a primary prevention strategy study which was conducted in people with the diabetes with no baseline cardiovascular disease. Only 10 milligram of atorvastatin was given to patients with diabetes. The other arm received only placebo. Surprising to see that there is a reduction of 37% within a matter of 3.2 years. Look at the levels of LDL cholesterol came down from 118 to 82 milligrams. So the more the reduction of LDL cholesterol got reflected in the reduction of cardiovascular events in people with the diabetes with no baseline problems of cardiovascular disease. That indicates all patients with the diabetes probably require statin. That was the first study which started showing us the best path for us to proceed. The second study is ASCOT study, which was conducted mainly in people with hypertension. 5,000 people were taken away from this particular study, and they were given one arm received only 10 milligram of atorvastatin and the other arm received placebo. So diabetes, hypertension, over and above antihypertensive therapy, only 10 milligram of atorvastatin was given. Surprising to see there is about 23% risk reduction, and the levels of LDL cholesterol came down from 129 to 83 milligrams. So the levels came down. The reflection is seen in the reduction of cardiovascular morbidity. Apart from these two trials, we also have TNT trial, where there is a reduction of LDL cholesterol by 22% compared to the 10 milligram dose of treat to new target study. One arm received 10 milligram, the other arm received 80 milligram. It's a chronic stable angina. Till that time, we were all using only 10 milligram. This was our first study to show that high dose statin in people with a stable angina will definitely give relief in the form of reduction of subsequent events. HPS study, heart protection study, 20,000 patients were recruited in this study. Among these, 6,000 patients with diabetes. Type 1, type 2, irrespective of the levels of LDL cholesterol lowering, we have seen benefits in people with the diabetes. So the first time the study has shown, both for primary as well as secondary prevention, people with the diabetes will get the benefit in the reduction of not only cholesterol, but also the reduction of cardiovascular events. Having seen this, I need to tell you that there is a good study called PROVE-TIMI-22 study, which was conducted in acute coronary syndrome. The more the levels of LDL cholesterol that are reduced, you can see the referent value 80 to 100. When you reach the levels of less than 40 milligram, you can see nearly about 39% reduction of cardiovascular events. 40 milligram, 40% reduction. That is a message, what we had obtained from PROVE-TIMI-22 trial. If you pool the data, it is surprising to see that there is a benefit of reduction of LDL cholesterol. Look at the one on the right side, you can see that the LDL cholesterol, which was seen as less than 50 milligram, has shown only 4% events, whereas compared to 70 to 100, it is 16%. So that shows the reduction of LDL cholesterol to the levels less than 50 milligram will show maximum benefit. Having seen this, this is a reduction, 50 milligram reduced, you can get a reduction of about 50%. But we need to remember, nearly about 40% of the patients, they, in spite of receiving high dose statin, are not able to reach the goal. This is about the non-statin drug, which need to be combined with the statin. Ezetimibe, cholesterol absorption inhibitor, was combined. You can just see that there is a reduction in particularly in people with the diabetes. There is a 14% reduction in the cardiovascular events in people with the diabetes compared to people without diabetes. It was only 6% reduction. So having seen this, MI reduced by 24%, ischemic stroke reduced by 39%. What is important in this particular projection is that diabetic people with the polyvascular disease has shown the maximum benefit when compared to only diabetic without diabetes with the polyvascular disease, indicating we know people with the diabetes may have ischemic stroke or an atherosclerotic cardiovascular disease in the form of a myocardial infarction or a peripheral vascular disease. If you have a people with a lot of complications, I think it is mandatory to add a non-statin drug like ezetimibe with the statin. This is a 4-year trial which had used the evolocumab compared with the placebo, had come out with the data that 15% reduction in the primary endpoints. It also shown in another study, PCSK9 inhibitor, the alirocumab, which has shown the reduction of 15% in the primary endpoints. All-cause death also came down by 15% in the analysis. Having seen this, I need to tell you, even in the 4-year trial, if you go into the depth of the details, nearly about 14% of them are still having problems of atherosclerotic cardiovascular disease in spite of the fact that they reach the levels of less than 30 milligram. So 14% still have the problem for subsequent events. So the residual risk, how to manage? So concentrate on triglyceride, concentrate on non-HDL, then concentrate on lifestyle modification. Try to rule out all secondary causes of hypertriglyceridemia before you jump to treat the triglyceride levels. Reduce your trial is a one trial which had used the icosapent ester, 4 grams, 2 grams in the morning, 2 grams in the evening, has shown beyond doubt the primary endpoints came down by 22%, the secondary endpoints came down by 26%. Management of diabetic dyslipidemia, let me try to concentrate on the risk categories. The risk categories, if you are in Europe, you can follow score system, score. Whereas in United States, people follow ACC-AHA calculator. In India, we don't have any calculator, but we are trying to tell you that there is an algorithm which had been published by Lipid Association of India, where you can identify an extreme risk group, and we can always try to bring down the LDL cholesterol based on these categories. So we, in 2016, we recommended that LDL cholesterol goal should be less than 50 milligram in very high risk individuals. This is European recommendation 55. In fact, how to do that? Concentrate on lipid values, concentrate on risk also. Only then it is possible for you to achieve the effective control of the LDL cholesterol to get the maximum benefit. This is the benefit of PCSK9 inhibitor. Almost all parameters, LDL, VLDL, LDL particles, remnant particles, everything comes down by the usage of PCSK9 inhibitor. I am not going into the depth of the details. This is my last slide, which tell you that if you have diabetes, if you don't have atherosclerotic cardiovascular disease, you can categorize into 2, high risk, the goal should be less than 70. Patient with a target organ damage, more than 2 risk factors, the goal should be less than 50. If the person has already suffered from atherosclerotic cardiovascular disease with diabetes, you need to bring down the levels to less than 50. It comes under the category of extreme risk category A. Extreme risk category B, you should bring it down to the levels of less than 30 milligram. This is a recent introduction called bempedoic acid, which has been introduced in the Indian market also. And these are the studies which favor the usage of bempedoic acid. Bempedoic acid is useful even in patients with the diabetes. Inclisiran is in the pipeline, which probably may come to India in the next year, which will reduce the levels of LDL cholesterol. So, ladies and gentlemen, in 2022, we have witnessed a lot of changes, advances in the field of lipidology, starting from statin, ezetimibe, PCSK9 inhibitors, icosapent ethyl ester, bempedoic acid, inclisiran. These are all the methods by which one probably can bring down the LDL cholesterol and give the reduction in the morbidity as well as mortality in those people with the diabetes. Except for the ACC-AHA, all other guidelines favor the reduction of LDL cholesterol with the risk, whereas ACC-AHA tells you only to reduce the risk. So this is my last slide. We need to be committed. We need to be aggressive. Not to curb just hyperglycemia all the time, but to concentrate on every possible risk factor in people with the diabetes right from the time of diagnosis. Thank you very much, ladies and gentlemen, for patient listening.
Thank you, sir. Thank you for the wonderful talk, and as usual, you rock, and you prove as a good teacher, sir. So actually, the higher doses of statin, every general practitioner and physician is very much having doubt about its side effects like body pain and of course the depression sometimes. What's your take on that, sir?
Now you talk about the statin intolerance. The statin intolerance can be many. One is the most important thing is the myalgia. Any patient who is started on statin will always come back to you with certain amount of muscle pain. What I do in my clinical practice, I tell the patient, the drug what I am writing is likely to produce some pain in the muscles. Don't come back to me. If it becomes severe, then you come for consultation. That's the best advice. So one-to-one interaction, patient-doctor interaction is a must before starting the drug statin. If you give high-dose statin, when it is really indicated, it does not mean that it will get pushed for statin intolerance. So statin intolerance in general, people have analyzed. Then the meta-analysis which was published in European Society of Cardiology, they mentioned 9% is the statin intolerance incidence. Most of the patients will have nocebo effect. All the time they perceive the statin, they will go and Google it. Yeah, statin will produce myopathy. The next week the fellow comes with the pain in the muscles. It may not be a real problem, it's only perceived. Nocebo effect or the placebo effect is the one that is seen in most of the patients and not the true statin intolerance.
Thank you, sir. Thank you.
Thank you.
Thank you, Dr. S.R. Narasingan, sir, for the speech. And thank you, sir, Dr. Pichumani, for chairing the event. I'd kindly like to request the speakers to collect their mementos of appreciation from the registration desk. Next, we have a GCDC oration chaired